Okay, my name is Ricardo Pardo. I am a Spanish breast surgeon working in the UK now for 2 years and a half. I was in Spain working in Madrid, Fundación Jiménez Díaz. This is one of the main hospitals from the Autonomous University in Madrid. And I came to England because, well, I love the way that breast is treated here. And I love the breast units concept, the triple assessment concept. And I've been working here for 2 years now. Well, when you get a diagnosis of breast cancer, there are different surgical options for you. It depends on how big is the tumor. It depends on many characteristics, but the most important thing is what the patient wants. Because if she wants a mastectomy from the beginning, we'll explain everything, we'll give all the information we can. We explain the conservative treatment is as good as a mastectomy. They are not going to live more having a mastectomy. That's a kind of concept they always have, thinking the mastectomy is the best. It is not. People think that having a bilateral mastectomy is going to cure them forever, and the cancer is not going to be. That's not true. It's most related to the type of tumor you have. They are very high-risk tumor, they are low-risk tumor. So whatever you have a mastectomy, you have a wide local excision, your survival will nearly be the same always. Don't take the decision thinking that a double mastectomy is going to save your life, because whatever will save your life is the team that will take the decision, and we will always do the best thing we can do for you. Well, the surgical options when you are diagnosed of a cancer, it depends on many characteristics of the tumor, how big the tumor is, how big the breast is. But in 80% of the cases, we can always preserve the breast. We do a wide local excision, with or without oncoplastic techniques. We have a lot of oncoplastic techniques that let us do a conservative treatment for the breast. When the patient comes to have a lumpectomy, a wide local excision done, it's all day case surgery. We're doing 85-90% of our cases. Whatever we do is day case surgery. So they don't have to be admitted at the hospital. They are only admitted if they have something special on the health. They are very high-risk patients, or they have huge bilateral mastectomy with reconstructions. In those cases, they can stay, but most of the cases, I think we're doing 85-90% of day case surgery. They can be discharged home that day. "20 years ago, the treatment of the axilla was completely different. 20 years ago, we were doing axillary no clearance for every patient. That changed 20 years ago when the concept of sentinel lymph node biopsy appeared. You have an axillary no clearance, you will get 25% of possibilities of having a lymphedema. If you have a sentinel lymph node biopsy, you have a 1% possibility of having a lymphedema. And having a lymphedema, that for the quality of life of the patient, that's really very bad. So we try to avoid it as much as we can. So doing that sentinel lymph node biopsy, we're able to identify if the nodes are positive. If they are negative, we don't do anything else. And now it's changing much more now because we're doing the targeted axillary dissection in patients that have neoadjuvant chemotherapy. It means they give the treatment first, they decrease the size of the tumor, and then they go for surgery. If the node is positive, we identify the node with a clip, and when we're going to do the surgery, we put a maxid on it. We're able to identify that node. We send that node to pathology, and if the node is negative, even if it was positive before, we will not have to do an axillary node clearance. That increases the quality of life of a lot of patients after neoadjuvant chemotherapy. The SOUND trial by Oreste Gentilini, one of the Italians, we were all waiting for the results, but the results shows that for low-risk tumors, you even don't need to do a biopsy of the axilla sentinel node because the results are the same. If in the ultrasound is look normal, you don't have to do a sentinel node biopsy, and the survival of the patient is going to be the same always. The axilla is going to have less and less effect on the treatment of the breast cancer in the future. The late sentinel lymph node biopsy is a really very interesting concept that we're dealing with now. If you operate on a DCIS is called ductal carcinoma in situ. It's a pre-invasive lesion. It's really not dangerous, but we have to do a mastectomy because sometimes they are huge. They are 10, 11, 12 centimeters in a small breast, so we have to do a mastectomy. What we're doing now, we do a sentinel lymph node biopsy at the same time. We found that only 20% of those cases will have an invasive lesion at the same time, but the other 80 will not need it. And still with the sentinel node, you would get 1% of chances of having a lymphedema. So we're trying to avoid it for that patients. What we do, we inject the MAC trace, this is dye of iron that goes to the axilla, and we wait. We don't do anything in theater. We just check that there is a signal in the axilla and we wait until the result. If the result of the mastectomy comes at DCIS, we don't do anything else. So we avoid doing that sentinel lymph node biopsy in all the cases. 80% of the patients with DCIS will not have sentinel lymph node biopsy, and that will mean that they will not have a chance of having a lymphedema. And if it comes with an invasive, then we will do the sentinel lymph node biopsy with the MAC trace, because MAC trace stays for a month or more time in the axilla, so we're able to retrieve it later. So that's a very good, interesting concept. We'll start doing it now. When we have to do a mastectomy, something we always try to avoid, but at the end we have to do a mastectomy. There are many different techniques. One is autologous tissue. Autologous tissue means taking your own tissue to do it. There are many techniques. One of the most popular now is the DIEP. DIEP is taking the fat from the vein and doing microsurgery and adapting it to the breast. It gives a nice shape, it's your own tissue. I mean, the complications can come as in any kind of operation, but the final result is really very good from the aesthetic point of view. We try to do it as much as we can. We used to do L, this latissimus dorsi, that is taking the muscle from the back and putting it back here, but I think it's been abandoned because the DIEP has much better aesthetic results. Then we have implants, and now the last we're doing it for a few years now, is doing pre-pectoral implants. The pre-pectoral technique will have less problem for the patient, it will be less painful. You don't touch the pectoral major, there's a big muscle here that we used to put retropectoral, the implants or the expanders. We're now doing it pre-pectoral with less complications, less pain, and the patient feels much better and recover much better. That's the main thing. We're using mesh to cover the implant. In some places they are now even not putting mesh, just putting direct implant with a special implant. So that's changing all the time. We're getting new techniques, new materials, new meshes, all the time it's improving, just trying to improve to get the best that we can do for the patient. What I always tell the patients is that if they have any doubt, if they don't have anything clear, call the breast care nurse. Because they will try to look for information in Google, they will try to go to internet. Sometimes that can be positive, and the breast care nurse will give her the places they can go that are really places which you can trust on. But I always tell them, your type of cancer is different from your neighbor, from your family, from your friends. So we will do a special treatment for the kind of cancer you have that's not related to others. And the breast care nurse will know everything. And if you want to come here back to discuss it again, we can do it as many times as you need.